Hello and welcome to this EMG Health webinar focusing on the overactive bladder. My name is Evgenia Kutsuki and I'm the editor of the EMJ family of open access journals. Our speaker today, Alan Wein, is a member of our editorial board. Alan is a professor and chair of the Division of Urology at the University of Pennsylvania School of Medicine and Emeritus Chief of Urology at the Hospital of the University of Pennsylvania. He's also the director of the Urology Residency Program at Penn Medicine. Among Alan's numerous professional and academic achievements is the International Continence Society Lifetime Achievement Award, which he received in 2020. Alan has authored and co-authored over 1,000 papers and book chapters during his career, and he's in fact the co-editor of the Campbell-Walsh-Wein Urology. Alan, welcome, and thank you for joining us today. The floor is yours, and we look forward to your presentation.
Thank you very much. What I'm going to do today is to try to summarize some issues about the overactive bladder, mainly terminology, controversies, and conservative therapy. These are my potential conflicts of interest, the companies for whom I consult. And basically, this is what I'll try to do today. Run through how the term overactive bladder came to be, what the strict definition of the term is, the importance of urgency in the diagnosis, the primary defining characteristic, some issues with the definition of urgency and how we perceive it. These are basically personal thoughts of mine, problems with the definition of overactive bladder, which I think you'll see, the prevalence of overactive bladder versus what the need or desire for treatment is, which are quite different, some thoughts about pathophysiology, and management in terms of behavioral modification, oral pharmacologic therapy, and combinations. The ones in yellow basically are fodder for another talk, what you do with refractory overactive bladder and what the new agents online are being investigated for overactive bladder are. So when I look for sources, or what I do when I recommend to you to look for sources about this, if you ever have to give a talk, I've used the AUA guidelines, which are revised only as necessary. I've used the EAU guidelines, which happily are revised every 1 or 2 years. And I've used the recommendations of the International Consultation on Incontinence, which is held every 3 to 4 years, and then which comes out with a book titled Incontinence the following year. The last one was 2017. We were supposed to have one in 2020, which is postponed. The next one will be in this calendar year, 2021. So first of all, how did the term overactive bladder come about? As you probably know, Paul Abrams from the Bristol Urologic Institute and I were responsible for the term. And the way it really came about was that in 1997, a pharmaceutical company wanted to have a symposium on what was then called the unstable bladder. We thought the symposium was a good idea, but we thought the name was a bad idea. So the company basically said, okay, we agree unstable bladder implies too much on the psychology side, so why don't you come up with the name? So basically, we came up with the name overactive bladder because we thought that it implied exactly what it was, and the conference name was changed. It was formally defined in 1999, and the definition was adopted by the International Continence Society, which is the repository of all terminology about lower urinary tract function and dysfunction in 2002. So this was the face page from the issue of the journal that summarized the proceedings of that conference. And the original goals of defining this condition as overactive bladder was to describe a common condition that was friendly to both primary care providers and specialists, and for which an initial non-invasive management strategy was possible with no complicated, no expensive, and no invasive studies, and to construct at the same time what we call a laundry list of safeguards, especially for primary care providers, which means that those patients should be referred to specialists so as not to harm anyone that had something else other than true overactive bladder. And this, in fact, was the laundry list that we came up with. Failure to respond to conservative medications or conservative treatment, which, as you'll see, includes behavioral modification and oral medications. Someone that had microscopic or gross hematuria. Someone who had had recent genitourinary surgery and developed their symptoms after that. Someone who had significant pelvic floor prolapse. A gentleman that had an abnormal digital rectal exam, a patient who had the symptoms characteristic of overactive bladder, but had what we called complex neurologic disease, that is spinal cord injury, Parkinson's disease, some cases of multiple sclerosis, someone who was in basically urinary retention, and someone who had significant pelvic or genital pain. So this was the definition and still is: urgency. With or without the initial definition said urge, it really should have been urgency incontinence, usually with frequency and nocturia. Now, for those of you who are very particular, you'll see that the original definition includes this somewhat paradoxical phrase, at least paradoxical to me: in the absence of an underlying metabolic or pathologic condition. And I'll speak more about this later, but technically, this is the definition. So since urgency is the prime characteristic, it was necessary to define urgency. The original definition of urgency was a strong desire to void accompanied by fear of leakage or pain. Now, in my opinion, and I think in Paul's as well, it was a mistake to leave fear of leakage out, because that is, in fact, I think, a part of urgency. The definition, however, in 2002 was changed to a sudden, compelling desire to pass urine that is difficult to defer. And I think you'll see that fear of leakage goes along with that. Leaving pain out was a good thing because that's more characteristic of another entity. So the exact definition, however, now, a compelling desire to pass urine that is difficult to defer, and you can add in your mind for fear of leakage. This is where overactive bladder symptoms fit in the scheme of stress incontinence and urge incontinence. So here's overactive bladder. 1/3 of patients with overactive bladder have urgency urinary incontinence, 2/3 don't. So these are overactive bladder dry. These are overactive bladder wet. Urgency urinary incontinence can coexist with stress urinary incontinence, in which case this phenomenon is called mixed incontinence, which makes sense. Mixed incontinence, unfortunately, at least in my opinion, is also applied to patients who have stress incontinence and also have overactive bladder symptoms, but no urgency incontinence. Now, I prefer to call these patients that have mixed symptoms because, in fact, in reality, they really do not have mixed incontinence. You treat them the same way, but just to keep them separate, I think that that's useful. So what does the phenomenon of urgency do? Well, urgency basically is the driver of all the symptoms of overactive bladder. It causes increased urinary frequency. It precedes urgency urinary incontinence. At night, it can result in nocturia, and it drives the behavioral adaptation that these folks who have overactive bladder make, which are mainly fluid restriction, so-called toilet mapping. They always know where the toilets in the vicinity are. They may exhibit prophylactic voiding, that is, voiding to avoid the sensation of urgency, and they may, in fact, restrict their activities so as not to get caught short. It's important to remember that successful treatment of urgency generally results in improvement in all or most of the other symptoms of overactive bladder. This is Chris Chappell's diagram about how urgency drives the other symptoms of overactive bladder. It's simple, it's to the point, and it's very accurate. It drives increased frequency and a reduced intervoid interval. It can drive urgency incontinence. It can drive nocturia, although most cases of nocturia are not due to overactive bladder. And it results in a reduced volume voided permicturition. So the first issue about urgency that comes up is urgency dichotomous, on or off, or is it a continuous variable? The second is, are there grades of severity of urgency? Can you grade urgency, or is it always all or none? And the third issue is, does urgency always end in a void or in a leak? This is another of Chris's diagrams that I've adapted to show the difference between dichotomous and continuous. Is urgency on or off, or is it kind of like a dimmer that occurs where it increases in severity until it reaches the point where you positively cannot postpone voiding, or is it kind of a combination? My personal opinion is that urgency can be truly episodic. 1 minute you have it, another minute you don't, or it can occur as the final sensation following a gradual buildup of the urge to void, which is normal. The urge to void is normal, but there's a definite point at which urgency, or at which urge changes to urgency. I think that urgency is episodic, but I do think it can vary in intensity. You can have mild urgency, which is fairly easy to suppress, and you can have severe urgency, which is not very easy to suppress, and which may result in urgency urinary incontinence. And so there are various schemes for grading urgency that you can actually use, and some companies use them when testing their product. Does urgency always end in a void or in a leak? No, it doesn't. It can be suppressed, and in fact, teaching patients how to suppress it is part of the behavioral modification regimen that everyone uses or should use. Is urgency always associated with detrusor overactivity on urodynamic studies? And you know, detrusor overactivity is the occurrence of an involuntary bladder contraction during filling. Is urgency always associated with detrusor overactivity? The answer is no. Urgency can exist without detrusor overactivity. This used to be called sensory urgency. I always thought sensory urgency was a great term since everyone knew what it meant. It meant urgency in the absence of an involuntary bladder contraction. Now this is called hypersensitivity without detrusor overactivity. Now the presence of urgency urinary incontinence, if you think about it, demands detrusor overactivity. In other words, you can't have urgency urinary incontinence without having an involuntary bladder contraction, whether or not it's demonstrated on urodynamic studies. If someone tells you that they have the type of incontinence that occurs because they can't get to the bathroom, and it's almost like a normal urination, that they leak a lot. Now, there's no way that that can happen without a detrusor overactivity. And whether you can demonstrate it or not on their urodynamic studies is really immaterial. You know that in real life, that person does have detrusor overactivity. It's an interesting compilation of data by Hashim and Paul Abrams, which showed that 64% of patients with overactive bladder have detrusor overactivity on urodynamics, which means 36% of patients don't. 83% of patients with detrusor overactivity on urodynamic studies have overactive bladder, which means that 17% of patients don't. It's just a phenomenon of the urodynamic study in someone that does not have the symptoms of overactive bladder. Mainly for primary care providers, how do you describe urgency to patients when you ask them if they have urgency? Well, I think that these are three pretty good ways. Comes from one of Paul Abrams' publications. A feeling that comes on suddenly, making you want to rush to the bathroom because you fear you may leak urine if you don't go right away. When I have to go, I really have to go. When I have to go, I have to rush because I think I may wet myself. Now, the current definition of overactive bladder is far from perfect. So what are the problems? Well, The term urgency is the sine qua non, eliminates a phenomenon that we used to call reflex incontinence. Now remember, reflex incontinence, the best example that I can give you is someone with a complete thoracic cord injury after spinal shock has passed. These people have involuntary bladder contractions without sensation. So obviously they don't have urgency. So this applies to any leakage due to involuntary bladder contractions or decreased compliance in neurologic patients, let's say, without the sensation of urgency, because there basically is no sensation. And that peculiar phrase at the end of the main definition, in the absence of metabolic or pathologic exclusions, it basically eliminates symptoms that are indeed covered within the main definition of overactive bladder due to urinary tract infection, can be due to bladder cancer or carcinoma in situ, can be due to a bladder stone or a stone impacted at the ureterovesical junction, can be due to a bladder injury or surgery, can be due to adjacent inflammation, such as a diverticular abscess next to the bladder. The point is, at least to me, that the symptoms are the same and the treatment of the symptoms is the same. But obviously, in the case of evaluating someone with overactive bladder, you should always look for and treat a presumed direct cause as well, because in addition to treating the symptoms, if you treat the direct cause, then you should be able to withdraw the symptomatic treatment and be left with a patient that has no symptoms suggestive of overactive bladder. So maybe while adopting the International Continence Society definition, it might be more accurate to think in your head, categorizing overactive bladder into neurologic overactive bladder and non-neurologic overactive bladder. And you can further characterize non-neurologic overactive bladder as being due to an identifiable cause, which is presumably reversible, urinary tract infection, bladder stone, etc., or true idiopathic overactive bladder with no identifiable cause. And of course, recognizing that the boundaries between these may not be discrete. It may not be possible to tell whether someone initially has a neurologic disease or not. And again, here's the same diagram looking at overactive bladder symptoms with or without urinary incontinence, looking at the overlap with stress incontinence, mixed incontinence, and stress incontinence plus overactive bladder dry, remembering that about 1/3 of overactive bladder patients have urgency urinary incontinence, so-called overactive bladder wet. What about interstitial cystitis or painful bladder syndrome? Well, this is a separate entity, even though they share certain characteristics of urinary frequency and actually urgency. But these patients generally have pain. They generally have pain in the pelvis, vagina, urethra, or perceived in the bladder. They generally, not always, but generally do not have involuntary bladder contractions or urgency urinary incontinence. And this is a diagram that is for the most part correct, not always, because I think that you can have both. I think you can also have overactive bladder with some discomfort, and you can also have painful bladder syndrome with urgency, but the urgency is generally because of pain. In other words, they have urgency, a sudden compelling desire to void because it hurts not to. It hurts generally during filling and storage. What's the prevalence of overactive bladder? Well, it's all over the board. You can see these are different age groups, men and women, fairly similar in these groups. This was the EpiLut study looking at only patients over the age of 40. Now, this is strictly by the definition. This doesn't say how many times urgency. It doesn't say how many times frequency. It doesn't say how bad the urgency is. This is just by symptoms. In the US, actually one of the, I think maybe the first study that was done, the so-called NOBLE study, 17% of the adult population, adult being defined as over the age of 18. And of those, this is where the original 1/3 figure came from. Almost 1/3 were wet, 2/3 dry. And in the US, you can see prevalence in men and women was the same, obviously increasing with age. And the prevalence of overactive bladder without incontinence higher in men than in women. Why? Because the outlet in men, I think, is stronger. They can suppress this, and also the prostate itself has a protective effect against leakage. Prevalence of overactive bladder with incontinence, and I think this would be the same in Europe, would be higher in women than in men, just because of the opposite reason, that the outlet is not as strong and it's not as easy to suppress these involuntary bladder contractions. One of the ways that you suppress them is by use of pelvic floor muscle contraction or periurethral muscle contraction. So the first question is prevalence, as defined in the previous study, equivalent to the need for or the desire for treatment? Well, the pharma companies would hope that the answer was yes, but I think the answer is pretty clearly no. So another question is, do symptoms progress? In other words, is treating someone that has fairly mild overactive bladder symptoms that's not terribly bothersome justified because you think if you don't, these symptoms will get worse? In some individuals, the symptoms do get worse, but I suspect this is due to other factors, such as the pelvic ischemia that often occurs with aging, such as obstruction as develops in the older male with prostatic enlargement, such as pelvic floor dysfunction like urinary or like pelvic floor prolapse. The overactive bladder symptoms, however, can also regress. So at least in my mind, I don't think that non-bothersome symptoms are an indication for treatment. So who actually needs or wants treatment? If you look at people that seek out treatment, why do they do so? Well, most patients that have significant urgency incontinence will do so. Patients that have severe urgency, that is, who have a near miss but don't leak, will do so. Patients with nocturia, although most of the time the nocturia is not due to overactive bladder, the most common contributing factor to nocturia is in fact nocturnal polyuria. And finally, those patients that have daytime frequency, although surprisingly, that's probably the least factor in the desire for treatment out of these four. But also it depends on what you can call the integral effect on the spheres of quality of life, which may in fact differ from group to group. In other words, for someone with a busy office job whose closest bathroom, let's say, is on another floor, the threshold for treatment may be quite different for someone who's retired, who spends most of their time at home, and who has a bathroom convenient to the room in which they spend most of their time at home. This is just a simplified drawing of all the spheres of quality of life that overactive bladder can affect: sexual, occupational, domestic, social, psychological, and basically physical. If someone has severe overactive bladder, they're not going to go, or they will have a little hesitation about going on a 5-mile hike unless they've had absolutely nothing to drink, in the previous 8 or 10 hours before. So with overactive bladder, what is it that we're trying to explain if you're trying to explain pathophysiology? Well, trying to explain either involuntary bladder contractions or urgency, which, as we've said, don't necessarily go together. Some people have urgency without involuntary bladder contractions. Some people have involuntary bladder contractions without a lot of urgency, especially those with neurologic disease. So there are different theories, and I don't think any one of these is entirely correct. And the different theories may explain why some patients with overactive bladder react differently to different treatments. Not every treatment is a cure-all, certainly. Chet DeGroat is a neurophysiologist from the University of Pittsburgh. This is probably the easiest to understand, that some loss of inhibitory modulation somewhere in this scheme of connections from the cerebral cortex to the bladder is lost. And therefore, there is an inhibition basically of this modulation, which causes, you can think of it as an over-facilitation of the micturition reflex and involuntary bladder contractions. And in some patients like MS urgency, in other patients like spinal cord injury after spinal shock, involuntary bladder contractions and incontinence without urgency. So at any place in this neurologic and muscular scheme, you can have a loss of inhibitory modulation. The myogenic theory comes from Allison Brading. It posits that there is a partial denervation which affects the smooth muscle of the bladder, which results in increased excitability of the detrusor smooth muscle cells and an increased ability for impulses to spread from cell to cell. Since bladder does have autonomous contractility anyway, at least in the human and many animals, this increased excitability and increased ability results in coordinated myogenic contractions and increased bladder pressure, which lead to afferent signals back to the central nervous system that result in the sensation of urgency. Carl Erik Anderson's theory is that during filling and storage, you should have no activity in the parasympathetic nervous system. In overactive bladder patients, at least some of them, you have a leak of acetylcholine from the parasympathetic neurons, either preganglionic or postganglionic, and this adds to the micromotion of detrusor smooth muscles, causing afferent activation, again, back to the CNS that's interpreted as the sensation of urgency, which can result in just urgency or urgency incontinence. This is Jim Gillespie's theory that bladder smooth muscle does exhibit autonomous activity, and it can be modified either by excessive excitatory activity or defective inhibitory activity. The details of this were unclear, but you sort of get the idea. The most recent theory, it's actually not recent anymore, Laurie Berger, Carl Erik Anderson, and others, is that there are afferent receptors in the bladder and afferent nerves in the urothelium and suburothelium. And during filling and storage, compounds that are released here cause an activation of these. The urothelium can generate and release all of these neurotransmitters, and in addition, others. These are obviously excitatory in addition to prostaglandins that I've failed to list here. And these signals basically are transmitted to the central nervous system by nerves that you can identify suburothelially in the basal urothelium and in the smooth muscle and also in the lamina propria. And this is a nice cartoon from Carl Erik Anderson that shows this pretty clearly. So, well, are you confused? Well, yeah, sometimes I am as well, but I think you can say that no single set of data explains all involuntary bladder contractions or occurrences of urgency and frequency. There seem to be four that are valid: faulty central inhibition, myogenic, which may be faulty peripheral inhibition or increased excitatory stimulation, the acetylcholine leak concept, and the urothelial initiation. If that's true, then in a given individual, overactive bladder may be due to only one of these or a combination, and this may explain why some treatments are more effective in some individuals than in others.